to circumvent my symposium here. So this is where we stopped off last time, correct? As things go. The topic is now early placental hormones. We'll get into placental hormones again, but this is the early placental hormones where the placenta is taking over function. Because previously, the thing that was functional for the placenta matured was the corpus luteum, and it was producing predominantly progesterone, but there is also some estrogen. So HCG maintains function of the corpus luteum for the first 3 months, and that's an early placental hormone, even before the placenta is actually completely formed or mature. This is produced during placentation. Estrogen and progesterone are also produced by the placenta early on and is going to contribute to growth and differentiation of both the mother and the fetus. So these are hormones that actually promote cellular growth. Estrogen and progesterone is indeed produced by the placenta throughout the pregnancy, and during placentation, when the placenta is trying to mature, the levels are really low, but after maturation, the levels go up and continue to rise as the pregnancy progresses. And so we actually have a peaking of estrogen, which is going to be very important. We'll talk about that in a little bit at the end of pregnancy. HCT, human chorionic thyrotropin, affects thyroid function, causing the thyroid gland to produce a thyroid hormone, and therefore boosting mom's metabolic rate, because besides herself, she's actually having to do things for the developing fetus. Extraembryonic membranes. So we have these membrane development that actually starts during the gastrulation process, which we're going to talk about. And that inner cell mass, or the embryoblast inside the blastocyst, which has the lining of cells called the trophoblast, will have some changes that occur that will help to form those extraembryonic membranes. And one side of this inner cell mass is going to produce the yolk sac, and that's going to be on what I call the luminal side of that inner cell mass, is the yolk sac. And then on the other side of the inner cell mass, we'll find that the amnion and then the amniotic sac will actually form. The importance of the yolk sac has absolutely no nutritive value in human beings. It is actually the site of early blood vessel and blood cell formation. A piece of the yolk sac called the allantois is going to actually contribute to the umbilical cord. So part of the umbilical cord comes from that. On the other side, on the side closest to the trophoblast landing gear, so to speak, is where the amnion develops, and it will become the amniotic sac. So what you have is you have this inner cell mass. One side's got the yolk sac on it, and the other side's got the amnion and amniotic sac on it. And the amniotic sac will grow all the way around that inner cell mass and yolk sac and actually envelop all of that, which is going to become the embryo. The chorion is the trophoblastic aspect that becomes the fetal part of that placenta. Let's take a look at our embryonic development, weeks 3 through 8. And gastrulation is the beginning of week 3 of our embryonic development, and it's going to create the basic framework of our embryo. And this is really important because that inner cell mass will now stratify into 3 distinct cellular layers. So 1 layer, 2 layer, and then the 3rd layer. So this is very, very important because cells from a specific layer are going to migrate to various areas of the developing embryo and then become tissues or organs or systems for the embryo.
Can you read that second? It says 3 something?
3 germ cell lines form. So 3 distinct layers or germ cell lines. And the reason I say germ cell lines is because they are very primitive, and those primitive cells will then actually change their cellular machinery to actually bring about the formation of the various organs and organ systems and tissues.
Is that the cell type that they want when they are looking for like an embryo, when they use the
embryonic cells?
Yes, the embryonic cells for like making new stuff, the stem cell research and that sort of thing.
Yeah.
Are those the type of cells, those germ cells that they want?
The stem cells are basic precursors even to the germ cell lines.
Oh, okay.
So, yes. So we have 3 primary layers or germ cell lines, and they're called endoderm, mesoderm, and ectoderm. The endoderm is going to be that cell line that's closest to the yolk sac, so that's on the luminal side. The mesoderm is right in the middle, and then the ectoderm is going to be that layer that's closest to the trophoblastic aspect of the inner cell mass or the amnion area. So these are the basic layers that will then give rise to basic tissues, organs, and systems. And the endoderm, that which is closest to the yolk sac, will form a lot of mucosal epithelia. So respiratory epithelia, lining the respiratory tract, digestive epithelia, lining the digestive tract, urogenital epithelia, lining the urinary tract, and then we have glandular epithelia, digestive as well as endocrine glands. And remember when we talked about the 4 major tissue types, epithelia was one of those, and so this is a big contribution to those. So I like to remember mucosal epithelia for the most part, as to help me remember some of the endodermal layers. Mesoderm, M for mesoderm is also M for all muscle tissue. So cardiac muscle, smooth muscle, and skeletal muscle tissue all come from that mesodermal or middle layer. Most of our connective tissue also, as well as serous membranes and urogenital organs. So urogenital organs are actually mesodermal in their origin. Ectoderm, all nervous tissue. So the outer aspect is nervous tissue and skin epithelia and its modifications, which are hair and nails and some of the glands. Remember, sweat glands, sebaceous glands, and melanocytes. So all nervous tissue, and then all things related to your skin epithelium and the things that are originating from that. So ectoderm is kind of the easiest one to memorize. Let's take a look now at the final stage of development, the fetal development, weeks 9 through birth. And we're going to take a look at the circulation of our fetus. Red stands for what in your mind? Oxygen-rich blood. Blue stands for oxygen-poor blood. And so what does purple stand for? Purple is a kind of a mixture of red and blue. So, and that's what I want you to realize. So when I say purple is a mixture of red and blue, it's a mixture of oxygenated blood and deoxygenated blood. So this is what's really important for you to realize. The fetus needs enough nutrients to develop. And so the oxygen levels of a developing fetus are never the oxygen levels of you. And so let's take a look at this. The reason that is because of various shunts that we actually find. The placenta, supremely important because the placenta is the life support organ for the fetus. Without the placenta, the fetus would not be, because the placenta is going to provide oxygen, going to get rid of carbon dioxide, going to provide nutrients, and going to get rid of wastes. So, going to function as your lungs, and going to function as the digestive system as well as the urinary system. So let's take a look at this as we would lungs. Do you remember what are the vessels leaving the heart? What do we call those? Arteries. And what are the vessels going back to the heart? Veins. So let's realize that the vessels leaving the fetus, and therefore the fetal heart, are going to be arteries, and the vessels coming back to the fetus are going to be veins. And in our pulmonary system, what type of blood is in our veins in the pulmonary system?
It's
Oxygenated blood. So right down here, as you take a look at the blood vessels in the umbilical cord, that red thing is a vein, and it's oxygenated blood. And so we have a single vein in the umbilical cord, and the blue things, or purplish things here, are going to be arteries going away, in other words, to the placenta. So the vein goes away from the placenta to the baby, and the arteries are going away from the baby or the fetus to the placenta. We have one vein and two arteries in the system. So take a look at that artery. It's nice and red, which means good oxygenation level. And I also want you to associate with it good nutrient level and very low carbon dioxide and very low waste level. So this blood is going back to the fetus, going to through the umbilical cord, going to go through the belly button, and look at it here as it goes up through the liver, and look where it empties into. What is that big vessel there that it's emptying into? The inferior vena cava. And the inferior vena cava should be blue, correct? Because that's taking used blood back to the fetal heart. And as we now mix used blood with fresh blood, you'll notice the nice color change at 3. It becomes purple. So it's a mixture of used and fresh blood. And what does the IVC empty into? The right atrium. So here we go. Here's our right atrium. And so that's why in that we actually have purplish colored blood. Now, is that the only vessel that goes into the right atrium? No. What other major vessel goes into the right atrium? Superior vena cava. And so that's what we see coming in here. So aren't we even further diluting the oxygenation level of this blood? That's fascinating. So we have oxygenated blood, which is mixing with all of this venous blood, but yet it is sufficient to nourish the growth and development of our fetus. So we go from our right atrium into our right ventricle, and then from our right ventricle we go into the pulmonary trunk and right and left pulmonary arteries. Well, what do you know about the lungs of this fetus? What are they doing? They're just growing. Yeah, basically nothing other than germinating, growing tissue. So how much blood do they really need? Just enough so that they can grow properly. And so if we have too much blood from our right ventricle going to the lungs, and the lungs, I want you to kind of view them as compressed sponges. You know, it's going to be hard to force blood into them, so that actually has a very high back pressure. And that's important because some blood will go into the lung tissue for nutrition, but the rest of the blood will go through a shunt. And that shunt is, in us, it's ligamentum arteriosum, but in the fetus, it's ductus arteriosus. And so that blood that is going to the lungs, if it's too much, will be shunted right on into our aorta through the ductus arteriosus. There's another shunt present, and we know that as the fossa ovalis. And where do we find the fossa ovalis? It's between our atriums, right and left atriums, the fossa ovalis. In the fetus, it's the foramen, because remember what foramen means, hole. It's the foramen ovale. And so we actually have a hole in the interatrial septum between the right and the left atrium. And this is where the bulk of the blood actually goes. So this mixture of blood that's going into the right atrium from the IVC and the SVC is going to actually primarily be transferred into the left atrium. And then from the left atrium, it will go into the left ventricle, and as you know, it will go into the aorta. And that's what's important. The bulk of the blood that goes into the right atrium will be shunted into the left atrium and then put into systemic circulation. And this is the freshest blood that the fetus has. So its oxygen levels are not like our oxygen levels, but they are high enough to nourish growing tissue and organ systems. And that's why we have two shunts. We have one for the bulk of the blood, and then we have another one for just in case the bulk of the blood didn't get shunted into the aorta, into the left atrium and left ventricle and out the aorta. So that's why those two shunts are present. And these shunts obviously have to close after birth because we don't want to have this shunting system occurring and bypassing the lungs. And that will, when the lungs actually inflate, then that pressure, that back pressure from them actually diminishes significantly, which diminishes the flow dynamics. So this purple vessel down here is our aorta. And that's to indicate to you again, this is a mixture of fresh and used blood. Our chart down here tells you what will happen to them outside of the fetal system. So fetal cardiac structures, let me actually erase some of this stuff, make it easier to see. So we have on one side fetal cardiac structures and then postnatal, that means after birth and delivery structures. So ductus arteriosus becomes ligamentum arteriosum. Ductus venosus will become ligamentum venosum, and we'll talk about that in just a moment. Foramen ovale, because foramen is a hole, becomes fossa ovalis, which is now just a depression. Our umbilical arteries, so we have two of those, will become what are called medial umbilical ligaments, and I'll talk about that in just a moment. And the singular umbilical vein will become the round ligament of the liver. And you guys remember the falciform ligament associated with the liver? And so our umbilical vein actually is that round ligament that we see. Going down into the written aspect of the notes, we have two umbilical arteries, which are branches of the internal iliacs. So remember our iliacs on the cat as well as the human. Internal means going into the pelvis. And these are sending blood to the placenta, and this is used blood. To the placenta means away from the baby, away from the heart. We have just a singular umbilical vein in the umbilical cord that is taking blood back to the fetus from the placenta, and that is fresh blood in that umbilical vein. It will ultimately become the round ligament of the liver, as mentioned earlier, and let's put that in our notes. What's important about this is that the umbilical vein goes through the liver and then into the IVC. Well, we have to feed the liver, and we will actually feed the liver just enough blood for the liver to grow. Most of the blood will bypass the liver in the ductus venosus. So this is bypassing liver. Because we want the bulk of the oxygenated blood into the IVC there by the diaphragm, because it'll go right on into the right atrium. So ductus venosus empties into IVC and then right atrium. In the right atrium we have the hole, the foramen ovale, which is the first major shunt between the atria, and will divert that right atrial blood into the left atrium. And the fossa ovalis is actually the last shunt to close after delivery. It takes time for that big hole to actually close off and become. It says fossa ovalis. That's when it becomes. Let's go ahead and change that to foramen. Because it's actually a hole in the fetus. Ductus arteriosus connects the pulmonary trunk to the aorta. Hopefully you guys saw that with the cadaver. It's the ligamentum arteriosum in the adult. And that is directed to divert blood from the right ventricle into the pulmonary trunk and therefore the aorta. We do want some bloods to go to the lungs so that we can actually nourish the growing lung tissue. I'm going to scroll the page up. And we're going to talk about some rudimentary fetal features here. Ultrasound was used to actually measure fetal length, and from fetal length determine where you are in your gestation or pregnancy. And they use this crown rump length. And so the fetal position is a curved position. Yes, you're all kind of balled up. And so that's what my cartoon is meant to represent. Head on one end, tail end, or buttocks on the other end. And so using the most distal aspect of the head and the most distal aspect of the rump and making a straight line between that, that's what the crown rump length is actually measured from. At 8 weeks in the gestation, you are a little over an inch long, 2.54 centimeters per inch, and we have 3 centimeters or 30 millimeters at 8 weeks as far as our length goes, and all of the systems are actually present in a rudimentary form. So we're completing that process of gastrulation and organogenesis. At 12 weeks, 4 weeks later, we are 3 times that size, so we're 90 millimeters, and we have crude facial features. And the reason I bring up crude facial features is because we all develop from a posterior, and everything migrates anteriorly in our development. And that's the reason why some people actually have some developmental defects, because we do not get complete anterior migration. And those people that I'm actually talking about are individuals with cleft lip or cleft palate. And that's the reason that occurred. Something actually interfered with completion of the anterior or ventral migration of the cell lines for us. And because we are migrating from that posterior lateral to ventral aspect, what I mean by crude facial features is your eyes are off to the side and your ears are behind that. So eyes and ears are present, but they're not in the proper location until about 16 weeks. At 16 weeks, the ventral migration has completed, and so your eyes are now in the front and not off to the side. Yes?
So for autism and fetal alcohol syndrome, the eyes are a little wider than normal too. Is that because of that? Does it stop at development?
Fetal alcohol syndrome, well, alcohol does interfere with a lot of development, and development is also migration of various organ systems and tissues. And so there's a lot of CNS that's being affected, and eyes are basically a portion of our CNS that we see. So yes, that may be part of the problem there. Lengthwise, at the 16 weeks times, you're 14 centimeters in length, and eyes and ears in normal position, face looks human. Backing up at 12 weeks, you can actually determine the sex of the fetus. That's as early as most people can. 17 to 20 weeks, you're now at the end of 20 weeks about 19 centimeters, and our notes say fetal position due to space and space issues. Because the way the fetus develops with the placenta and inside the amniotic sac, I liken the fetus to a little kid in a big bathtub. And so all the way up till about 16 and then 17 weeks, we're able to do backflips and forward spins and side rolls and all that stuff. But suddenly we are getting bigger than our bathtub. And we have to find a position to put ourselves in. And so that's what this is referring to. At about 17 weeks, we're out of space, and so we're confined, and we poke with our elbows and kick with our feet and hit with our fists, and mom feels that. She goes, oh, I can feel the baby move. And that's why quickening actually occurs. Eyebrows and eyelashes are nicely formed at the end of 20 weeks. And at 21 to 38 weeks, at the end of that 38 weeks, we're about 36 centimeters in length. And eyes are opening, spontaneous respirations are occurring, nails are complete in their formation. It's best to be born at 38 weeks. Up to 40 is considered pretty normal, and 42 weeks is actually considered late, and they'll try to induce the delivery process. The issue, though, is more commonly with a problem with preemies. And preemies that actually are delivered at around 27 to 28 weeks have a really good chance of survival. The earlier we get with that, the more intensive the care is required for those for survival, and also therefore consequences of intensive care treatment and effects of that. The reason that we have problems with survival when we're born at 27 to 28 weeks in that early time frame is that we have a lot of immaturity. Our lungs are immature, the hypothalamus is immature, and we actually don't have what are called full-term looking skin. When you see a preemie, you can tell it's a preemie, not just because of size, but when you take a look at their skin compared to a full-term baby, there's a big difference. And you can see the veins on a preemie really, really easily because we don't have that sub-Q fat deposition that actually has occurred with a full-term baby. And so at the end of that of a normal pregnancy, we're getting a lot of sub-Q fat deposition. And so our notes here say that lungs are immature, and that's because surfactant issues. Maturity of the lungs also means that surfactant is being produced in sufficient quantities to prevent lung or alveolar collapse. And so if you don't have enough surfactant to prevent alveolar collapse, you are on a ventilator. And that's one of the things that we often see with preemies. They, don't have enough surfactant, and so every time they exhale, those alveoli collapse. So then they have to inhale very strongly, and they don't have the musculature either to actually do those forceful inhales to keep their airways open. And so the ventilator blows air and blows their little alveoli, or their little teeny balloons, up for them. And then when exhalation occurs, collapse, and then let's blow them open again for them. Exhalation occurs, collapse, until enough surfactant is formed. And the stress of all of this is actually one of the things that can actually promote or induce surfactant production. The other thing, too, is, and remember, surfactant is being produced by what are called type 2 alveolar cells. That's what that type 2 is off to the side. Type 1 alveolar cells are simple squamous epithelium. Type 2 alveolar cells are kind of cuboidal and produce surfactant. Yes?
How long does it typically take for the baby to be on its own?
How long does stress, how much stress, or
until the surfactant is done being
that can be quite variable. It's going to be variable based upon how premature the newborn is, and how much stress is actually required to get that surfactant actually going. Typically a few days, a couple, 3, 4, and the longer they are on, therefore the less trauma that's actually being induced to their lung tissue. So, and that's why when women go into preterm labor, they actually try to stop it. And the reason they try to stop it is even the stress of preterm labor is actually felt by the fetus and promotes surfactant production. So, hypothalamic issues. Temperature control is one of the hypothalamic jobs. And so the hypothalamus is not yet figured out how to do temperature control very well in preemies. And so they have those temperature instabilities, and you find them in incubators, and the incubators are environments that are designed to keep them warm because they can't keep themselves warm. The other thing that will contribute to helping them to stay warm is having that nice little fatty coat underneath their skin. And so they don't have that fatty layer, so therefore they have less ability to thermally insulate themselves. And the other thing that that fatty layer is important for is for the normal thing that happens when you have a newborn, when the baby is first born.
They have weight loss.
Pardon?
They have weight loss, they lose weight.
They lose weight. Absolutely. Newborns are supposed to lose weight normally. They were designed to lose weight. One of the things that's very easy to actually see is they look a little puffy, don't they? They all look a little puffy for a full-term newborn. And after a couple of days, they're less puffy. And that means that they actually peed off some of that fluid, correct? The other thing is that nice fatty layer is going to take care of them while we wait. And what are we waiting for? Mom's milk production. And so that's another thing that's very important for having a full-term baby, is that full-term baby has adequate fat deposition to rob from while we wait for mom's milk production to come in. Because even though mom has colostrum, calorically, that's not very high. It does help a little bit, but that's like, having a couple of spoonfuls of Jell-O on a daily basis. It's just not going to actually take care of your caloric needs when you are now forced into an environment that you didn't want to go into in the first place. But maybe you did. Let's go ahead and take a look at the effects of the pregnancy on mother. Overall, everything becomes well vascularized in mom. Estrogens and progesterones actually help to contribute to that. The normal weight gain for a pregnancy should be 25 pounds. And the amount of calories that a woman needs to ingest daily over her normal daily intake is only 300 calories a day. And so it is kind of interesting when they say, they come back with a big old plate and say, oh, I'm eating for two, and I go, you have to think, 2 adults or 1 developing baby and an adult, So that's one of the things that actually sometimes the misunderstanding is it's not 2 adults you're eating for, but that contributes, though, because of that misunderstanding, that does contribute to the excessive weight gain that we actually see a lot of during pregnancies for a lot of women these days. So 300 calories a day, isn't that about half of a peanut butter and jelly sandwich? One of full-fat yogurt, something along that line. And pregnancy is not a fun thing. So eating more food is more fun. And so people prefer to eat a little bit extra. And they can. Okay. Changes that mom will experience due to placental hormones. Remember, the placenta is going to be responsible for the bulk of our H or hormonal production after P with a line above it's after the first trimester. And estrogen and progesterone, as I mentioned earlier, is produced by the placenta throughout the pregnancy. Even during the early stages of placental development or placentation, we'll get some estrogen and progesterone from it. But it's nowhere near sufficient to actually maintain the uterine lining and the development of maternal anatomical structures as well as fetal anatomical structures. But they indeed increase throughout pregnancy. Estrogen and progesterone levels continue to actually increase. Estrogen and progesterone give women their wonderfully thick hair and nails, nice strong nails, and can also promote hyperpigmentation. And so a lot of the linea alba gets a little dark in its coloration, line down from the belly button on up. And then some women, unfortunately, get what's called the mask of pregnancy or chloasma. And that's where they get hyperpigmentation, mottled hyperpigmentation of their face, neck, and shoulders sometimes. And it takes some time for that to resolve. Sometimes it never resolves. And so women will resort to bleaching agents to actually get rid of it. Breast tissue growth is that is due to estrogen and progesterone levels. Indeed, that's what happens with puberty also. So now we're having high estrogen and progesterone levels that are going to cause increased breast tissue growth because the breast tissue is going to then actually be charged with milk production, and certain hormones are actually required for that. Interestingly, the ligaments of the pelvis become lax at the end of pregnancy due to high estrogen levels. So they get softened up at the end of the pregnancy, and you can always tell when the estrogen levels are getting pretty darn high when she starts to waddle when she walks, because loosey-goosey ligaments allow for the hat to suddenly fit. So the head actually descends, and then it's a little bit more difficult to walk around when you have a head right inside the pelvis. Uterine lining. Remember, maintenance of the pregnancy is absolutely a progesterone dominant situation. And so the uterine lining is maintained because of high progesterone levels throughout the pregnancy. Estrogen, of course, is still important, but that progesterone is vital to keep the uterine lining from sloughing. Corticotropin releasing hormone. That's way back from our endocrine chapter. Corticotropin releasing hormone. That cortico is referring to the adrenal cortex, and it's going to actually, during pregnancy, it actually promotes the release of aldosterone. And aldosterone is going to be responsible for causing sodium retention, sodium reabsorption from the filtrate. And when you bring sodium back into your system, what always follows it? Water. And that is what contributes to the puffiness and edema that women will actually develop and cause that fluid retention for us. Human placental lactogen is misnamed. Remember I said the germinal epithelium is misnamed? They had an idea, and the idea was wrong. So, see, you guys should never feel bad for being wrong. It's just that these people got to be wrong, and still we have to learn it the wrong way. No, they don't correct it after it's actually realized. But human placental lactogen. Well, placental, it tells you where it's coming from, and we actually are talking about placental hormones. And lactogen sounds like it has something to do with lactation, but it doesn't. HPL has everything to do with promoting an alternative metabolic pathway for mom. You guys remember when we did our metabolism chapter that glucose, primary fuel. Well, HPL tells mom fatty acids, primary fuel. Glucose, not primary fuel for mom. That's what HPL does. It says, let's go ahead and use fatty acids as your preferred fuel, obviously except for the brain. So it's preferred over glucose, which means then what happens to mom's blood glucose levels? They go up. Well, and that is good because we want mom's glucose to go to the baby. And so that's what HPL is for. HPL is actually for good fetal growth by feeding the baby glucose. It also interferes with maternal insulin activity, which means that glucose doesn't go into the cells so readily, which still keeps glucose elevated in the bloodstream. So I said it interferes. It doesn't completely negate. It just interferes, and so we have a higher basal glucose level in pregnant women. And so when you're no longer pregnant, your basal or baseline glucose level is lower. When you're pregnant, your basal or baseline glucose level is higher because you are feeding the fetus.
So what's happening in gestational diabetes when you're dealing with that?
Yeah, gestational diabetes, the HPL is overly strong.
Okay.
And that's what causes gestational diabetes. So then glucose levels are overly high, and also high glucose levels means we're feeding the baby
Double time.
more sugar, which means the babies get bigger, and that's part of the problem with gestational diabetes is actually not just the high blood glucose for mom, it's big babies, and it's hard to deliver big babies. So That's what's bad about gestational diabetes. It promotes problems with actual delivery because of baby size. Again, human chorionic thyrotropin raises mom's metabolic rate by increasing thyroid hormone because it acts like TSH, thyroid stimulating hormone. Our topic here of physiological changes, these are problems that some women can experience. Not everybody has these symptoms that I've got listed here, but this is to explain where the symptoms actually come from. A lot of women will have morning sickness, whereas some will not. And this is actually due to elevated estrogen and progesterone levels. She hasn't had time to develop tolerance to them. And once tolerance develops, typically the nausea and vomiting of pregnancy actually goes away, or that morning sickness. But some women never actually seem to be able to tolerate the rising estrogen and progesterone levels and are sick throughout their pregnancy. I feel sorry for those individuals. The motility of the gastrointestinal tract is diminished, which means constipation is a problem, and this is actually due to progesterone. High progesterone levels actually are relaxing to smooth muscle. And if you relax the smooth muscle of the digestive tract, you don't get that lovely peristalsis, and so things stay in the digestive tract longer. Heartburn is more of a problem in the third trimester. We have this nice big gravid uterus moving up, and deflecting all of the internal organs, pushing the stomach up and out of its natural position, causing acid reflux at the gastroesophageal sphincter and heartburn symptoms. And so a lot of times for those that have this problem, they'll prefer to sleep a little bit more upright, not so supine or flat in their bed. Pillows are a pregnant woman's best friend. Urinary system, we have more urine production as mom is responsible for disposal of fetal waste material. Also, the growing uterus or gravid uterus will be pressing upon the bladder and also making it more difficult to hold as high of a volume of urine, and so more frequent urination will occur because of those two factors. Going to move it on up. And respiratory system, really interesting. Some women have abundant estrogen receptors on their nasal mucosa, and the rising estrogen levels will cause nasal congestion for them, but not most, it's just some. And then, of course, shortness of breath starts to develop as we get into that third trimester, and that is due to gravid. Gravid means nice big pregnant uterus full of the fetus, actually rising up, limiting diaphragm action. So pushing up and everything has to move out of the way. Cardiovascular system is where the largest changes are actually seen in everyone. And that's because total body water rises. Remember we talked about aldosterone production is increased, and so we have more fluid retention, and that's a big reason why total body water rises. So she gets an increased intravascular volume as well as interstitial volume. We get a 24 to 40% increase in blood volume, and that is mostly due to a 50% rise in plasma volume. And this causes a dilutional anemia. So think of it this way. So we have a salt solution, say it's 10% salt, and I pour in more water, that is no longer going to be a 10% salt solution. And so that's why we see a lot of anemia with pregnancy, because we've increased the plasma more than anything else as far as blood goes, and that causes a dilutional anemia. And so iron supplementation is a very common thing to do to try and promote more red blood cell formation. as well as folic acid, making sure prenatal vitamins have plenty of vitamin B12. All of those things that are needed to make more red blood cells are part of the prenatal vitamins. Of course, iron can be constipating for some women and also can upset the stomach. So you have to kind of experiment around and see if you can find a formulation that most women can tolerate. Also, when you increase intravascular volume, you'll increase your cardiac output. So that increases heart rate and blood pressure. Absolutely. So blood pressure can go up. And then varicose veins. Uterus starts in the pelvis, and we have our internal iliac arteries and veins in the pelvis. And which ones are easier to compress? Arteries or veins? Veins. So veins are bringing blood back to the heart, so that means we're doing kind of a pseudo mini tourniquet at times. And so that decreases venous return in that area. And as that uterus grows in size and actually comes out of the pelvis, it will be filling up the abdominal cavity and act like a tumor and compress when you're laying down on your back, it will compress which two vessels as you are laying down on your back? The inferior vena cava. Remember, the aorta has got a high pressure, and so even the gravid uterus may reduce a little bit of flow of the aorta, but nothing like the inferior vena cava. And do most women like laying on their back, flat on their back? No. Yes, it feels bad because you're getting decreased venous return, and that's why they prefer to lay on their side. And this also, though, because of this enlarging uterus, is going to kind of have that tamponading or a tourniquet-like effect on venous return, will cause increased edema of the lower extremities, correct, as pregnancy wears on. And also the varicosities can occur because we're also getting decreased venous return, backing up down into the legs and stuff along that line. But the varicosities that most women have most problem with are not just varicosities of the legs, but of the anal area. That's where hemorrhoids come from. A lot of women will get hemorrhoids during pregnancy because of this gravid uterus decreasing venous return.
If you have a preeclampsia or a toxemia, what is that just your cardiac system not working at all because of the high blood pressure? I mean,
preeclampsia and toxemia is almost like, I'm going to oversimplify, it's like an autoimmune response to the pregnancy. And so things are actually being activated that are deleterious to the pregnancy, and the pregnancy is protected actually more than the mother. Yeah, and the mother actually suffers the consequence of that. So the technical term for labor is parturition.
Oh, because you're parting.
Yes, you're parting. So parturition is labor, and then delivery, and most of us call this birthing or birth. It's interesting, labor typically starts around 280 days after the last menstrual cycle. And it's really interesting because estrogen level at this time is really high. It's been increasing throughout the pregnancy, and now it's kind of hit its peak. And high estrogen levels are important because it stimulates the myometrium to create oxytocin receptors. And many people know oxytocin is necessary to go into normal labor. So before, the myometrium didn't have oxytocin receptors. Now the myometrium is going to get oxytocin receptors and therefore be responsive to oxytocin. The important thing too is, remember, progesterone. Progesterone is important in maintaining the uterine lining, but also progesterone has a tendency to be relaxing on smooth muscle. And that's what myometrium is. So if it relaxes smooth muscle, it means that it's trying to inhibit contraction of smooth muscle. So we have oxytocin receptors being placed on our myometrial cells, and we have progesterone trying to tell those now oxytocin receptor rich cells, don't do it, don't do it, it's not time. And so we have this little battle, and sometimes our progesterone levels aren't high enough, and our oxytocin receptors and their irritability actually take over and give us that process called Braxton-Hicks contractions. And obviously Braxton-Hicks actually must have been the one to name these. But it's also referred to as false labor. This is due to myometrial irritability due to waxing and waning progesterone levels with rising oxytocin receptors. You know that the woman is in false labor because she looks too happy. I have never seen a woman in true labor really look happy. And the ones that think they're in labor and are happy because they're in labor, it's hard to tell them that you're not in labor. So you let them come in and take up a bed, and you monitor them for a little bit, and you check their cervix, and nothing happens. There's no cervical dilation. And you tell them, go ahead and go home. This was just a dry run. It's a trial run. And so they go home disappointed. And you know that next time that you'll see them, they won't come in looking so happy. They don't call it labor for nothing. Okay. What's interesting, because now we're loading up the myometrium with oxytocin receptors, because oxytocin is going to be produced by, interestingly, mom and fetus. So the fetus definitely has a say about when labor is initiated. So not just the mom's oxytocin levels that she's creating, but fetal oxytocin levels are going to go up at the proper time of fetal maturity. And the fetal oxytocin, in addition to the mother's oxytocin, it's actually both, will actually cause this prostaglandin production. So this prostaglandin production will not occur without fetal oxytocin production. The prostaglandins are going to be produced by the placenta. And prostaglandins by themselves can actually stimulate strong uterine contractions. But when you have prostaglandins and oxytocin, you have definite, effective, strong uterine contractions. So we need prostaglandins and oxytocin both to give effective, strong uterine contractions. When you have strong uterine contractions, you will actually be forcing the presenting part of the fetus against the cervix with these strong uterine contractions. And that presenting part is going to push down on that cervix because of being pushed by the uterine contractions, and it's going to cause cervical stretching and dilation. That cervical stretching and dilation then causes a positive feedback. It's actually like a reflex arc. It causes a positive feedback on the neurohypophysis to release more oxytocin. And so oxytocin is released, which contributes to more powerful uterine contractions or more effective uterine contractions and further cervical dilation. So then we have now this nice positive feedback loop actually occurring. We need to have prostaglandins and oxytocin for our strong uterine contractions, and we also have to have estrogen present, because without estrogen, it doesn't matter how much oxytocin we have, because we won't have oxytocin, the adequate oxytocin receptors on our myometrium. So estrogen, estrogen, prostaglandins, and oxytocin are all vital for the initiation and maintenance of a sustained true labor. When women are pregnant, their doctors or caregivers will tell them, don't take anything over the counter. The strongest thing that you can take over the counter is Tylenol, is typically what they're typically told. And that's because there are actually quite a few over-the-counter medications that can actually be harmful to the fetus and inhibit the actual event of true labor. And those things that can inhibit true labor are antiprostaglandin medications, which are very common over the counter. And antiprostaglandin medications are typically called NSAIDs, nonsteroidal anti-inflammatory drugs, or aspirin. So both NSAID-like medications as well as aspirin actually are antiprostaglandin, which can definitely impact true labor formation and maintenance. Now the woman is happy but not. And we have true labor. She wants to get this over with. She's tired of being a human incubator. So it's time to get this baby born. Most of them want you to take it out of them, but it's got to be them. So let's talk about the 3 stages of labor. Stage 1, 2, and 3. And 1 is called dilation, and it is the longest and most variable of the stages of labor. It starts at the time of onset of true labor to full cervical dilation, and that is typically 10 centimeters. What that means is during a vaginal exam, when you go in and try and find the cervix, it is not there. So there is no cervix at all. All you feel is presenting part. And the typical presenting part is the head. And the most common presentation is face down. And that's if the woman's on her back, so supine. So face down means facing the sacrum, correct? If it is face up, facing the symphysis pubis, that causes for a more difficult labor because the proper descent and flexing of the head is not easily done in the other position. With true labor, the uterus actually has peristalsis from the fundus on down. So we have nice, strong, ringing contraction all the way down to the cervix. Contraction frequency increases. Cervix effaces first when we have true labor actually occurring. Effacement means thinning. So the cervix, remember, it has length to it. We had an external os, an internal os, and a canal in between. And effacement, because now we have the head pushing down on it, it thins out. It literally squishes it into flatness and almost the size of a thick piece of paper. That's type of thickness. After the effacement, then we have dilation that actually occurs. So effacement occurs before dilation occurs. Throughout this labor process, it's not uncommon for the amnion or amniotic membrane to rupture, and then the amniotic fluid is released, and it's typically clear. And I'm going to ask you, do you guys know what causes the production of the amniotic fluid? It's kind of interesting. The bulk of amniotic fluid that's actually being produced is actually urine. It's fully functioning kidneys. And what do you know about fetal urine? Sterile. It's as sterile as can be, correct? And so that urine is it going to be taking care of a bunch of wastes? No, because that's what the placenta is for. Mom's system is still taking care of the waste. And so the kidneys are functioning in that they can make urine, but they don't have to really do a job yet other than to actually make urine. And that's what the bulk of amniotic fluid is at the time of delivery. Now, is all amniotic fluid clear? No. Sometimes it's not. And when it's not, got any idea what color it is? Brown green. And why would it be brown green? Because there is a product in the rectal vault in the rectum that's called meconium. And defecation can occur in utero, and that meconium is then now dispersed into the amniotic fluid, and it makes the amniotic fluid viscous and thick. And already we have been experiencing normal respiratory activity, not respirations, but respiratory activity. And so the problem is, because of that, the meconium's floating around now in the amniotic fluid. that meconium impregnated amniotic fluid can get into the respiratory system of the fetus. And then when the fetus is born and tries to take a big breath, we plaster all along the respiratory tract this lovely meconium stuff. And so that's why meconium during delivery is not a happy sign. And you typically want to suck as much of this stuff out of the nose, mouth, and every area that you can in the respiratory system quickly before the baby's delivered and takes its first breath. So it's not uncommon for the person doing the delivery to say, don't push. And the reason they're saying don't push is they're trying to suck the airways out. So before the final delivery, which is going to be the stimulus for breathing, actually occurs, we've got most of that muck out of the system. Again, this is the most variable and longest part of labor. 4 to 24 hours is the typical time range, and so that's quite variable. And it's typically longer for first deliveries, and shorter as subsequent deliveries actually occur, but not necessarily. Engagement is where the infant's head is in the pelvis and beyond the cervix. So it's past the cervical barrier when engagement occurs. Stage 2, expulsion, or more commonly most people call delivery. So this is from full cervical dilation to birth and typically only takes an hour or less. And contractions are very strong. Every 2 to 3 minutes, mom wants to push. And indeed, when they start to tell you, I want to push, you can almost guarantee that the cervix is completely dilated. Some will want to push before that, but the cervical dilation will complete probably not long after that. Crowning is going to occur also during this expulsion stage. And crowning means that the head, or the presenting part, has reached the perineum, or the pelvic floor of the woman, and is now distending the vulva and labia majora and minora, as well as the rectal opening. So everything is pushing down, and literally, I hate to tell you guys this, but the fetal face is scooping down along the rectum. It's between the face and the sacrum's the rectum, and it's scooping on down that area, and it's going to scoop any fecal material out during that time. So it's not uncommon for defecation to actually occur during this time frame, because everything's being pushed on out during this descent. Another reason why the nose is so flat. It's laying along the sacrum. Head comes down. We've got crowning, and then mom pushes. The perineum stretches naturally, and sometimes it doesn't stretch well enough. And so an episiotomy is typically done if it doesn't stretch well enough. But over time, if given enough time, it will stretch, because women have been doing this for a long time. So given enough time, that perineum will stretch. The opening will accommodate the bowling ball that's going to come on out, and comes out face down, as I was mentioning. The normal presentation is face down, and then there's a normal rotation that actually occurs. And so then the face will go from face down to the side. And so we'll be looking at the side. And then that means then it's easy enough to actually deliver the shoulders, because this is where gestational diabetes is a problem. Not only, it's not the head that's big, it's we got a football player coming on out. Football players always have big shoulders. And so the shoulders are bigger than the head. Under ordinary circumstances, the head is the biggest thing coming on out. So once the head comes out, everything else is easy. So the head comes out, and just a little bit of downward traction is applied to the head, and what's called the anterior shoulder comes out underneath the symphysis pubis, and then you pull up, and the posterior shoulder comes on out, and if you're not careful, they'll squirt out at you. They come on out real easy at that stage. But, they have a bungee cord attached to them, so typically they don't go very far. Okay, so that's expulsion to delivery of now the neonate or newborn. Stage 3, baby's been born, cord, you take your time and you can clamp and then cut the cord, and typically these days they like to put the baby on the mom's chest and start the bonding process. And during that time period when mother's bonding, then we need stage 3 to complete, and that's called the placental stage, which is delivery of the placenta. That usually occurs in less than 30 minutes. A lot of times people want to speed it up, but you have to realize it's a normal process and has its own time frame. Uterus is still going to contract during this time frame. So even though now the fetus, which is now the neonate, is out, uterus is still contracting. And is doing this because now we're empty and we're going to contract on down to make ourselves smaller. Well, the placenta is still inside, and contracting on down to make yourself smaller with the placenta the same size causes the placenta literally to shear off the uterine wall. So it shears off the uterine wall. And what do you know about the placenta that's very important to realize? Is it just from the baby? No, it's baby and mother make up the placenta. So when the placenta shears off, we're ripping some of mom's wall off, her uterine wall, during this time. It's meant to be shed, but still it's vascular. And so these uterine contractions basically cause the uterus to get small enough to actually act like its own tourniquet. Because when the placenta comes off, if you just pull the placenta off, you have this big gaping wound, but as you get down smaller and smaller in size, that gaping wound gets its own little tourniquet effect, and that helps to prevent bleeding. This is where, when we have Rh incompatibility, this is where the blood mixes. This is that process. Adjustments of the neonate at birth. 3 things. CNS has to be properly functioning, so a depressed baby will have a depressed response. And when I say a depressed baby, that means drugs in the mother's system. Okay? So CNS of the baby, it has to be mature and fully functional and not inhibited by any method. And the CNS of the baby will go, oh my gosh, where am I? I was in a nice warm bath, and now I'm in this cold, cruel world. And that stimulates the CNS to actually respond. And most people would scream at that type of a transition. So environmental and temperature changes. Cruel world. The ordinary response would be to scream. Carbon dioxide is now going to also accumulate because most of the time we are going to go ahead and clamp and cut the cord, and we are no longer getting nutrient and gas exchange from the placenta. And if you're not breathing, carbon dioxide is building up in your system because normal cellular metabolism is going to occur. Carbon dioxide builds up, pH drops, so acidosis develops. And the lungs. The lungs have to be properly mature. And what I mean by that is we have to have plenty of surfactant in the lungs. And so expansion of these never expanded lung material is, the first breath is the most difficult breath, even with surfactant. And so you have to get that first breath happening. And that's why most of the time you like to hear them cry, because crying involves effort. And so that effort will help with actually forcing air into the lungs and the amniotic fluid out. And surfactant will actually then prohibit deflation or collapse of the alveoli. And with every breath that newborn takes, more alveoli open, more alveoli open, more alveoli open. And so proper respiratory function. So surfactant, remember, is designed to actually decrease alveolar collapse. With premature infants, we don't have enough surfactant, and that's where we get our problems. Occlusion of the fetal vessels and shunts. Our umbilical arteries will become medial umbilical ligaments. Remember that these are coming off of our internal iliacs and going towards our belly button. And so they actually are on the inner surface of the abdominal wall where we actually can see them. If you look at the, was to take a scope and take a look at your inner abdominal wall, we could actually identify the medial umbilical ligaments. Umbilical vein is going to become the round ligament of the liver. Our ductus arteriosus is going to collapse to become the ligamentum arteriosum. pressure differential changes because of the expanded lungs will actually help to promote that. And then the foramen ovale will become the fossa ovalis. And this is the last shunt to actually complete its closure. And takes many months to do that. As far as lactation, we need prolactin for that. So prolactin is going to be the hormone that's going to stimulate milk production. Estrogen and progesterone are going to get the factory ready, and prolactin is going to tell the factory produce milk. So prolactin is what actually stimulates milk production, and the first milk product is called colostrum. It doesn't have much in the way of lactose in it. Has actually a high in protein content, not so high in fat. Is the first secretory product and rich in immunoglobulin A, which remember is on mucosal surfaces. The nice thing about colostrum is it has a laxative effect and helps the newborn evacuate or get rid of its meconium. Meconium looks like black-green tar, really sticky, sticks to the anal area and crevices there, and you have to work gently to actually get it all removed. When the infant suckles, is at the breast, it actually stimulates the hypothalamus. So there is like a little reflex arc. And this causes the hypothalamus to continue releasing prolactin, keeping those prolactin levels high, keeping milk production promoted. And the suckling also causes pulsatile oxytocin release. Oxytocin is good though, because remember it's going to be responsible for uterine contractions, and the uterus isn't back to normal size in a day or two. It takes time for the uterus to get back to normal size. So oxytocin release will help to stimulate uterine contractions to get that uterus to continue to diminish in its overall size. And also oxytocin stimulates the muscle cells around the lactiferous ducts and actually causes milk ejection. So you actually milk can squirt from the breasts, from the nipples. Baby crying also stimulates oxytocin production and also milk ejection or milk letdown. Human milk has a much higher fat content than colostrum, high in nutrition, lots of immunoglobulins to protect the newborn from the nasties in the world, and abundant in vitamins except for vitamin D. And so that's why a lot of pediatricians or family practice providers recommend vitamin D supplementation. Nursing is fascinating. Regular nursing causes the release of beta endorphins. You guys remember beta endorphins from our first semester, the end, when we were talking about the central nervous system and neurotransmitters and stuff? So beta endorphins are those feel-good natural opiates. And what's interesting is they inhibit the release of gonadotropin-releasing hormone. And if you aren't releasing gonadotropin-releasing hormone, what do we know about your FSH and LH levels? They're down, which some women will use breastfeeding or nursing as a form of pregnancy prevention. But whenever you actually introduce any other form of feeding, then you have irregularity in suppression of gonadotropin-releasing hormone and can have some occasional ovulation that will occur. So some women don't want to give up breastfeeding. Do you have any idea why? Oh my gosh, what do you think? Why do we have an opioid addiction problem, people? People take opioids because they make them feel good. And so that's why people get addicted to their running highs and stuff like that. So what we actually have here with beta endorphins is we have this release, which it makes mom feel good, which also promotes bonding, correct? So this is a mechanism by which you promote bonding and breastfeeding, but also can delay actually weaning of the child with some individuals. And a lot of cultures actually promote breastfeeding until age 2, yeah? Until they're able to feed themselves on their own. But I just say whatever works for you. Just to let you know, people who like to run a lot and get that runner's high, what does that mean about their gonadotropin releasing hormone levels? They're low, which means then they are also low on FSH and LH levels. And if they're a female, what do you know about their estrogen and progesterone levels? All low. So all of those
That's why if
things.
someone's having a problem getting pregnant, they'll suggest that they stop running.
Those, ultra athletes will be amenorrheic or without any menses. And one of the things that you got to get them to do is to stop all the beta endorphin rushes, and which makes them, of course, feel bad, which is rough on people, but it is what it is. So that's the end of that chapter, and we'll do some